All right, I think we're live.
Yeah, I have to mute it really quick so you won't be able to hear it.
Sure.
Okay. Hello, Web Shadowers. Thank you all for attending our session this afternoon. Today we have the pleasure of hosting Dr. Phan, who will be teaching us about internal medicine. As always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. With that being said, Dr. Phan, you may start whenever you're ready.
Okay. Do I have to put this into presentation mode or?
Yeah,
Um,
if you can.
okay, perfect. All right, can you see my screen okay? All right, perfect. So first off, thank you so much for having me. This is a really great opportunity for me, for you guys to learn more about internal medicine. I know there are a lot of doctors out there that you could have, requested a shadow, and I'm really, this is a great pleasure for me. So let's get started. So a little bit about myself. So I have an MD and an MS. I was born in Southern California. I was raised in Orange County. Funny enough, I went to art school for high school, and then I decided that I wanted to become a physician. So after I got into Johns Hopkins on a full ride, I decided to major in molecular cellular biology. I did some research here and got some pubs out, and didn't really get to focus on arts much. But whenever I went home, I'd always play piano. After this, I attended Georgetown and I got a master's in science in physiology and biophysics. And then after that, I decided to go to St. George's University for my medical school. And I did a lot of stuff there. I graduated summa cum laude. I was part of the Gold Humanism Honor Society. I also participated in a lot of research. I had a very productive medical school career. And then recently, I just matched into internal medicine at Arrowhead Regional Medical Center, which is the university hospital for California University of Science and Medicine, which I'll be starting in July. I also have been teaching for about nearly a decade now. I've been a teaching assistant. I've been a tutor on CHEG for a lot of courses. And so I really developed a passion for medical education, which is why I'm here as well. And I developed a company called White Coat Tutors. We really specialize in USMLE, which is the United States Medical Licensing Examination, the step one and step two, and residency applications. And aside from all the academic stuff, I also do stuff outside as well. I like to do hiking and outdoors. I was a Boy Scout and achieved Eagle Scout. And I also like to do powerlifting. As you can see here, I am solving a Rubik's Cube while squatting. And this is just me playing piano at Carnegie Hall in New York. All right. So, what is internal medicine? So, really, it's a field where you can work with patients that are all adults. That means anyone who's age 18 plus. And you treat them as long as they are non surgical patients. But a lot of the time, we do coordinate it with surgery. So, how do you become an internist in the United States? So, the first things first, you need to finish an undergraduate degree, but also complete all your prerequisites for medical school. That's like taking organic chemistry, biochemistry, and physics, and all those other classes. Following this, at some point in your undergraduate or afterwards, you can take the MCAT, and then you can apply to medical school through AMCATs. Once you're into medical school, you can then you'll complete 4 years of that. Sometimes it's a little bit different depending on where you complete medical school. There's usually a preclinical portion where you study the basic sciences. And during this portion, you study like physiology, you study pathophys, you study pathology, microbiology, pharmacology, and kind of just get your ground basis for your knowledge when you enter the wards, as in clinical rotations. Following this, people usually have around 2 years of clinical rotations where you will rotate through core rotations. Those will include something like internal medicine, surgery, family medicine, pediatrics, OB-GYN, and surgery. And then after that, you can choose to do sub-internships or audition rotations or elective rotations and kind of anything you want to do. Like, for example, since I'm going to internal medicine and I'm not going to specialize in emergency medicine or ENT, I decided to do some electives in those during my 4th year. And then during medical school, so after the 2nd year, you have to take the USMLE step one. That's usually what's required to get you into clinicals, although some schools are a little bit different. And typically after your 3rd year of medical school, you'll take the USMLE step two CK, clinical knowledge. And then you'll use that score, both those scores to as part of your application to residency. And then at some point after you complete medical school, you'll take step three, and then you're done with the United States medical licensing examinations. Now, During your fourth year, you're going to be applying to residency programs where you'll submit an application through ERAS. And through that process, you'll attend many interviews. And hopefully, in the March of your fourth year, you will be matched into a program of your choice. So once you get into internal medicine, you will complete 3 more years of training as a resident physician, which is where I'm currently doing. And then after that, you'll complete the ABIM exam, which is going to get you boarded in internal medicine. Okay, so internal medicine is very broad. It covers almost every single organ system, every single thing you can think of. And the prospects for after residency are wide. You can just stop right after residency and just work as a hospitalist. You can be an outpatient physician, see patients in the clinic, or you can subspecialize. And here are like some of the options you have. For me personally, I'm interested at this point in pulmonary and critical care. And then potentially afterwards, there's an option to pursue interventional pulmonology to do some more procedures. So I know a lot of times people will say that internists don't do procedures. Well, that's kind of changing because all the people who come in with myocardial infarctions who need to get reperfusion therapy, that's what interventional cardiology does. And so nowadays, a lot of these fields of interventional medicine are growing a lot in the field of medicine. Okay, so today's case is going to be about chest pain. I think chest pain is a very, very, very common presentation to the emergency department, and I really have to thank our friends in the emergency department who figure out if these patients require admission to the hospital or if they can be discharged home. There are a lot of different causes. We'll talk about all of them today, but I think today's focus will be really on cardiac chest pain. All right, so chest pain basics. Like I said, we're going to focus on cardiac chest pain. And cardiac chest pain is also known as angina pectoris, or just angina. So angina by definition is chest pain due to an ischemic myocardium. And ischemia just really means that you're having reduced oxygen or blood flow to an organ because there's a blockage in that vessel. And so in this case, that'd be the coronary arteries. Whether it's due to a vasospasm, which really just means, so vaso means blood vessel, spasm means like a muscle spasm where the muscle contracts. And so, oops, sorry about that. Okay, so continuing, where was I? Right, so vasospasm. So vasospasm is when your blood vessels contract, and when it contracts so much, you can cause a reduction in blood flow, and that will by virtue cause a turbulent blood flow. So that's one way you can make this happen. And then another cause is actual just stenosis. That can be from long-term things like having long-term diabetes, hypertension, smoking, high cholesterol, and it really just causes your blood vessels to get narrower and narrower and narrower to a point where the amount of blood flow going through that vessel is reduced. And then that causes ischemic myocardium and you get chest pain. Some other causes of non-cardiac chest pain would be like the esophagus. So someone who has gastroesophageal reflux disorder can present with a substernal chest pain, kind of like right in the belly, but it's kind of mistaken for chest pain. But also it's kind of important to mention that women who present with chest pain often will have atypical signs of chest pain, such as abdominal pain. So it's something to we should consider. Lungs. So I mentioned lungs because there's something called a pulmonary embolism. Essentially what's happening is you're getting reduced blood flow to the lungs. And so you're having, you're basically kind of infarcting that area and you're causing pain. And then bone is something like costochondritis, where you have inflammation, or really not bone, more like the cartilage of that area becomes inflamed. So you have costochondritis. So let's go ahead and talk about a little bit about the anatomy of the heart here. So this is the front view. So if you're looking at my chest, this is the view you'd see. I mean, it's a little bit more rotated, but this is good enough for our purposes. This here is the LAD, which is the left anterior descending artery. That's going to be also known as the widowmaker. It's the very commonly occluded vessel. And as you can see here, there's little blue areas where it's going to supply blood. Now, we also have the right coronary artery, RCA. It's going to supply this entire area over here. And it's also going to supply something called the SA node, the sinoatrial node. And then the left coronary artery can also branch to the left circumflex, which supplies the left wall. And then usually in about 85% of people, the right coronary artery will go in the back and it will supply the inferior wall and the posterior interventricular septum. Do you guys have any questions at this point regarding the anatomy of the heart? All right, then we'll move right along. Okay, so coronary artery stenosis. We talked about vasospasm, but I think I want to provide a better picture for how atherosclerosis can happen. So in this case, you can see the lumen in a normal healthy person looks like this. Over time, if they have diabetes, hypertension, they smoke, let's say, a pack a day, they have high cholesterol, what can happen is it can get smaller, 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 and eventually occlude. So let's talk about this disease process a little bit. So you have your blood vessel here, and these little tiny cells here are called the endothelium. They kind of layer this inside layer of your blood vessel. Now, over time, if you have all those diseases I talked about, or you have like a smoking history, what can happen is this endothelium can become damaged. And when that becomes damaged, you can have these cells called macrophages. They're kind of like the recycling bin or like the trash cans of our body. They'll come in, and then on top of the lipids that come in, they'll try to eat up LDL, which is low density lipoprotein. And then what will happen is that you form this thing called foam cells because they can't really digest the fat there. And they'll form this thing called fatty streaks. After these fatty streaks form, you can eventually form a fibrous plaque. And what happens is that you have smooth muscle that proliferates. This is due to things like platelet-derived growth factor and fibroblast growth factor, which you might be hearing about in your biochemistry, genetics, biochemistry courses at school. And then once this happens, this is when you have a lot of problems. We can talk a little bit about that later. Can someone name this entire disease process for me? Okay, so this disease process is, okay, so it delays comments for about 45 seconds. Well, this disease process is, it's called atherosclerosis, and it's associated with those modifiable risk factors I talked about. So for example, if someone's smoking, you might want to tell them to stop. If they have hypertension, you want to control their high blood pressure. If they have high cholesterol, take their cholesterol medications. It's really not super difficult to control as long as you go see your doctor and you take your medications as prescribed. And always, I think exercise is very, very good also for cardiovascular health. Okay, so let's talk about angina, or as we called it earlier, angina pectoris. So how do we differentiate the kinds of angina that someone can present with? Oh, great. I saw the comment box. Many said atherosclerosis. Perfect. That's good. So I want you to start thinking about some of the things on this slide here. I differentiated typical versus atypical angina, stable versus unstable versus Prinzmetal angina. So can someone tell me what typical angina would present like? There are three things. I'll give you guys a few seconds to enter your stuff into the chat box, into the Google form. And then if some people can also chime in and tell me what they might think stable angina is, unstable angina, or Prinzmetal angina is, that'd be great. If not, just say so, and I'll just like talk through it real quickly for you. Okay, some people said chest pain, some people said shortness of breath. Okay, so I think we need to be a little bit more specific than that. So the chest pain actually has to be, okay, a sharp pain. So let's talk about sharp pain in the chest, right? So sharp pain in the chest could just mean that you have like trauma to the area. Sharp chest pain could be pleuritic chest pain, which means you have pain when you take a deep breath in. So really radiating pain. Okay, radiating pain, that's a feature of a myocardial infarction, but I'll get to that later. Some people said nausea and weakness. So I'll give you guys the answers. So the number one is substernal chest pain. So your sternum is right here. Here, I'll change my angle a little bit. Your sternum is right here. So the pain is really right there underneath the sternum. And the pain is characterized as a pressure-like sensation. So usually that's usually what they're gonna present with. Stable is when it goes away with rest. Okay, I'll answer that in a second. And then the third thing is that it'll relieve with a medication called nitroglycerin, which is a group of meds called nitrates. Or if they rest for 10 minutes and the pain goes away, that is typical angina. Now, let's talk about stable angina. So stable angina, yes, it is stable is when it goes away with rest. So stable angina, let's talk about the atherosclerosis model again. So you have this vessel, it's about 70% occluded. That is stable angina. And this is a reversible type of ischemia. You can always reverse this. It's not irreversible damage yet to your cells. And during stable angina, it's usually due to atherosclerosis, like we said. There's no pain when you're at rest. So someone who has stable angina won't have pain when they're sitting in a chair like this or laying in bed or reclining in a recliner. However, when they exercise, it'll start to hurt. And then when they rest, it'll go away, or if they take nitroglycerin. Now, unstable angina is going to be 90% occlusion. This is still reversible. I know it sounds like there's like no way turning back, but this is reversible still. And it's usually due to, so remember in the previous slide, we talked about the fibrous plaque. It's when this plaque ruptures. That's usually what's the cause of unstable angina. And in these people, they're going to have chest pain while reclining in their chairs and resting. And then, but this one also, the pain is going to be relieved with nitroglycerin. Prinzmetal angina is going to be the vasospasm we talked about. So I know some of you are studying biology. So if you guys remember the calcium, what it can do in the cell is calcium can cause release of vesicles, which is one thing it can do to trigger more neurotransmitter release. But the other thing it does is it causes smooth muscle contraction. So remember, your arteries also contain a layer of smooth muscle inside. And when that smooth muscle contracts, it can cause the vessel to get smaller. And so Prinzmetal angina can be due to people, usually you'll see it in like a young person who is abusing drugs like cocaine or other drugs that stimulate your sympathetics. The reason is because your sympathetics have usually stimulate alpha-1 receptors, which is a adrenoreceptor. And then when that is stimulated, it'll cause contraction. So how do we treat this? So we talk about calcium. So really you just block calcium. So we use calcium channel blockers. Good job. All right, so this is your answers. If you just want to screenshot this real quick, you can go for it, or you can look at the YouTube video later. All right, so beyond angina. So what do you guys think is the biggest thing we have to rule out when someone comes in complaining of chest pain? Like, I guess to rephrase this question, what is the most dangerous thing we need to rule out? And of course, so just, type in your answers and then I'll take a look at them. And then, when we're going for patient care, we need to make sure we take a good history, do a good physical exam, diagnostics, and combine all of that to really figure out how we're going to help our patients. This is kind of the cornerstone of internal medicine. And you're always going to hear, take a good history, because most of what you're going to need to help your patient is in their history. So I'm going to wait a few seconds for your guys' answers for the biggest thing we need to rule out when someone comes in complaining of chest pain. Heart attack, good. Very good. Does anyone know the medical term for heart attack? Perfect, myocardial infarction, very good. Cool, so we definitely need to rule that out, because if they have a myocardial infarction, we need to get them to the cath lab as soon as possible. That's assuming that your center has a cath lab. All right, so what is the difference between a myocardial infarction versus angina? So essentially, it's just the progression of this over time. It's just, so unstable angina, we said, is due to a plaque rupture, right? So same thing with myocardial infarction. It's so bad that it causes now irreversible damage to the cardiomyocytes, which are the cells of the heart. So cardio, which is heart, myo, muscle, sites. So the heart's muscle cells, essentially. And so when you have irreversible cell injury to the heart, there's cell death there. And so when cells break, you guys have learned about apoptosis and necrosis, right? So in this case, this would be a necrosis of those cells. And when cells necrose, they're going to break open and they're going to release enzymes. And that's why you always hear sometimes in like movies, TV shows, you just hear around the hospital, what are the, did you check the cardiac enzymes? But really there are some specific ones that we're looking for. We'll talk a little bit about that later. All right. And then regarding the risk factors, we talked about them earlier. Again, smoking, high blood pressure or hypertension, hyperlipidemia, and diabetes. And those are pretty much, and then like obesity as well, which also contributes to all these other problems. All right, so our case today is about Bob. He's a 55-year-old male who was brought in by ambulance to the emergency department. He's complaining of severe chest pain and is seeking medical attention. So he comes in and Bob says, "Doctor, it feels like an elephant is sitting on my chest." So right away, I hope you guys are thinking that this is that pressure-like sensation, right? Imagine if someone sat on your chest. It'd feel like a pressure kind of discomfort, right? So that's what a myocardial infarction would kind of feel like. So I want you guys to think about, I'm sure you guys have a lot of sessions already, and maybe this has been discussed, but I want to go over it again. Do you guys know what the proper structure of a history is and what kind of questions we should ask to get a better understanding of Bob's current situation? And a little hint for the history, there's something called the SOAP note, SOAP. That's the history part is really just in the S of SOAP. It's going to wait for the answers to roll in. Okay, so for the second question, some people said, when did it start? His symptoms and how long he has been experiencing them. Someone said a sample mnemonic, which I haven't heard of, but I'm sure it's great. Subjective information, good. That's what S stands for in SOAP. Any medications he's taking, good. Okay. These are really good. How long has it been hurting? Great, great. Quality of the pain. All right. So yeah, we're getting a lot of things we want to ask. And okay, past surgery, family, social, good. So we're getting a lot of things that are kind of jumbled up in the structure of the history. So let me just walk you through how I would go through this history. So SOAP stands for subjective, objective, assessment, and plan. But all the history is really in subjective because once you get past S, it's no more, the patient isn't really telling you anymore. So to make it simple, subjective is what the patient tells you. And the subjective portion, the first thing you're going to want to get is something called the history of presenting illness, or HPI. This is where all those questions of, you guys are saying, see, how long has it been hurting, quality of the pain, anything that makes the pain better or worse, those kind of questions will go in there. So some questions I would ask are, when did the pain start? How long does the pain last? Is it constant or intermittent? How would you characterize or describe your pain? That's really important because what if they say sharp versus pressure like, or like a tearing chest pain? Because if someone has like a tearing kind of chest pain that radiates to the back, that's more of a dissection kind of thing, not a myocardial infarction. Does the pain move anywhere? So why is that important? Does the pain move anywhere? So when you have an MI, you can have radiation to the left jaw and the left shoulder. That's called referred pain. Is this the first time you ever had this before? They might have had some kind of chest pain in the past because they've had angina before. And any other symptoms, a lot of the times these patients are diaphoretic, which means they're just sweating a lot. So these are all really, really good questions we can ask them. And another thing we can actually ask is, how severe is your pain on a scale from 1 to 10? They'll likely say 10 out of 10, but after they gave me some kind of medication, the pain went down. So these are some really good questions to ask in the HPI. Now, following your HPI, you can start asking for, someone else said it, the past surgery, family, social. But additionally, you need to ask for any allergies, because if you give them medications or anything procedural, let's say they have a latex allergy, which we don't really use in the hospital much anymore, but that's really important to know. And then also their current medications and if they're compliant with them. So let's say, so we look for surgery if they've had any previous catheterization before, like have they had an MI before? Have they been to the cath lab before? Have they had a stent put into this artery before? Family history, why is that important? Because if there's a family history of MIs in the mother and father and other first degree relatives, it's likely that this patient is going to experience one. Social history. So what's in a social history? It can be a lot of stuff, but to focus here, we can look at smoke use, tobacco use, alcohol abuse. We can look at illicit drug use. We can figure out if his job is stressful. Being a lawyer can be very stressful, or even being anything can be very stressful. And emotional stress can also trigger chest pain. And then asking if he exercises and what his normal diet is like. Why do we need to ask that? Well, if he has a really poor diet, like he eats McDonald's 3 times a day, 7 days a week, that's not so great for his health either. So these are all really important things that we need to consider when we're taking a patient's history. And then finally, the medications, we need to make sure they're compliant. He could be prescribed a long laundry list of medications, but if he's not taking them, then it's not going to really help him, right? So once we get this really big picture, as you can see, we're building up a very big story here, then we get a better understanding of what's going on with the patient. And getting a good history is something I think medical students should really focus on in first, second, and third year. And I think if you guys do scribing or anything like that, this is also a good opportunity to practice your history taking. All right. Any questions regarding history taking before I move on? I'll go to the next slide, but I'll be looking at the chat box. Okay, so Bob tells you his HPI. So he says, Doc, it started about 30 minutes ago out of nowhere. I was eating breakfast and all of a sudden I felt a pressure-like pain in my chest. That should, and it says it feels like an elephant sitting on my chest. So this is definitely going to clue you in that, okay, I need to be thinking first thing on my list needs to be myocardial infarction. The pain is a 10 out of 10 in severity. It's very bad. And it moves to his left jaw and arm and isn't going away. This is very classic as well. So he's brought in by ambulance, which is what I said in the initial case presentation. And they gave him something to put under his tongue. Can someone guess what medication that is that was put under his tongue? And he said, I've never experienced an end like this and I'm scared. A lot of the times we as healthcare providers need to remember that the patient's day in the hospital is the worst day in their life. But for us, it's just another day at work. But we need to remember that. We need to be humbled by that. We need to remember to treat every single patient as if they're our family member, and we need to be compassionate with them. We need to help them out during their time of need. Great. Someone said nitroglycerin. Exactly. Nitroglycerin is that medication I was talking about earlier. No, aspirin you don't really put under the tongue, but it'd be nitroglycerin. It's a little tablet you put, it's a little tab, it dissolves and you put it on your tongue and then it helps with chest pain. All right, so what are some things that we can tell this patient to help comfort him? This is about compassion and humanity in medicine. And I think this is what really makes people great doctors. It's taking the time to sit there and understand what's going on and really connect with the patient. Someone said everything's going to be okay. You'll get through this. Okay, that's good. We'll give you the best treatment we can. Perfect. These are all really good responses. We can figure this out and help you get back to daily life. Great. Reassure him that you'll do your best to treat him. Great. So one thing we need to make sure is we can't guarantee any outcomes, but what we can guarantee is that our healthcare team is going to do the best. Someone said assure quality of team, right? You're in good hands, we'll take care of you. These are all really good responses. Just remember that we need to reassure the patient that we're going to give them the best care possible. We're going to, I sometimes will say, I'm going to treat you like you're my family member. And, I'm very happy that you called the ambulance and came to the hospital at this time so that we can treat you, so that we can help you as best we can. And someone else, a good point here, someone else said also let him know his family will be updated. This is really important. Sometimes when you get into the hospital, patients are being moved everywhere around everywhere. And so then they don't have their phones on them, their family's worried. And so a good thing is to have good communication between the nurse and the family and the doctor and the family as well, just so that they know what's going on with their family member. Great. Another answer someone said is, we are here to help you. You're in the right place to receive the best care. Perfect. Great answers, guys. And always allow the patient to ask any questions he needs, and always break down medical jargon. Don't just start shouting out a bunch of different medical terms. Use more simple words that patients can understand. So that's another thing that'll help help them understand the situation better. All right, so let's continue going on with this past medical history, social history, surgical history, family history. So I want you to quickly read this and tell me what you guys think about his history at this point. So I'll just read through this. His past medical history. So he's a type 2 diabetic. He has high blood pressure, high cholesterol. He has a history of rheumatoid arthritis. Current medications are glipizide and metformin, which are 2 medications for diabetes. He's on valsartan, which is an angiotensin receptor blocker, which helps with hypertension. If you guys ever studied the renin-angiotensin-aldosterone system, this is part of that pathway. So you can block that pathway, which helps a lot. Atorvastatin, which is a statin drug, which blocks HMG-CoA reductase, which helps with cholesterol, and the methotrexate, which is an immunomodulating drug for rheumatoid arthritis. Regarding his past surgical history, he had a cholecystectomy 2 years ago, which just means a gallbladder removal. He has a 20-pack year smoking history. That's pretty significant. The way you calculate pack years is how many packs per day they smoke and times how many years they've smoked. So if he's smoked 2 packs per day times 10 years, that's a 20-pack year smoking history. He drinks a 6-pack of beer each weekend, which isn't bad. High risk drinking for males is, I believe, I think it's 10 or 14 drinks per week. And then he denies any illicit drug use. So if he denies illicit drug use, vasospastic angina is much, much, much lower on my list of problems. Differentials. And in his family history, mom died from a stroke and dad died from a heart attack. Those are both vascular issues. So he has a family history of vascular issues. Perfect. So someone said some things that are important are 20-pack year smoking history, family history. But I think the most important ones, so 20-pack year smoking history is a modifiable risk factor that we can reduce. So we can counsel him and educate him on what tobacco can do to him. And we can also tell him, give him resources to help him quit smoking. Additionally, diabetes is also something that we can help him control better. We don't have any labs here at this point because we can't tell if his diabetes is well controlled or not. Before I continue, just let me know if you guys can figure out what the lab value I'm talking about is for diabetes. It's not serum glucose, it's something else. And it tells you a little bit about someone's glucose control over the past 3 months. His blood pressure control, that we got to see the vital signs before we can say anything, but hopefully he's taking his valsartan, and hopefully he's taking his statin and his methotrexate for his cholesterol and his rheumatoid arthritis, respectively. So if someone can figure out that lab value, that'd be great. And then we can move on. I'll give you guys about like 20 more seconds. Hopefully the answers roll in soon. Someone asked, hypertension along with diabetes, if poorly controlled, can be a problem. Yeah, so let's talk about this a little bit. So hypertension means you have, hypertension, there's different kinds, but we're assuming he has something called primary or essential hypertension. And basically this is usually due to things like something that'll cause your arteries to get stiffer. And so then over a long time, because you have so much pressure flowing through these stiff arteries, you can have endothelial damage, which can produce atherosclerosis. Diabetes can do the same thing. High glucose is going to help. Also, diabetes and hypertension are both going to cause them to become stiffer. And so then you can have more endothelial damage. Diabetes, also high glucose can reduce your immune system as well. So someone said hemoglobin A1C, perfect. So A1C is what you're going to measure in someone with diabetes. So if someone comes in with the diet with a A1C of like 9 or 10, I know that they're not taking their medications appropriately, and likely their glucose is going to be somewhere around like closer to like 200-ish, which is way higher than what we want. Someone said he's a good candidate for a heart attack and other cardiovascular diseases because of his diabetes, smoking, illicit drug. He doesn't use illicit drugs, by the way, and past family history. Very good. Only thing we're not sure about is his medication compliance. So this is something we can ask him if he's been compliant with his medications, and we can double check his we can double check his labs to see if that'll reflect that. 6.5% or more A1C levels are diabetic. Yep. Cool. All right. Perfect. So this is physical exam. What do you guys think about it? So I'll read through it. His blood pressure is 150 over 96. Heart rate is 110. Respiratory rate is 18. And oxygen saturation on room air, by the way, is 92%. He's a little anxious. He's diaphoretic, so he's kind of sweating, but he doesn't appear toxic, which means he doesn't look like he has like a really bad infection going on, and he's obese. His cardiac exam, you hear the S1 to S2 heart sounds, no additional heart sounds. His pulmonary exam sounds clear, and he's not having any kind of increased work of breathing, so he's not like, so that's good. And then his GI exam is pretty normal, and everything's normal basically. So what are we thinking about with regards to his vital signs and some of the other things in his physical exam? I guess one question I can ask is, do you guys think his high blood pressure is okay in this situation? Could it be okay? And why is his heart rate so high? Normal is 60 to 110. Normal blood pressure is less than 120 over less than 80. Someone said low O2 sats. Okay, so I'll address that one real quick. So actually, anything above 92% is actually okay if you go look up any like evidence-based guidelines. So actually, if anyone's over 92%, they don't need to be on oxygen. So he's not actually low on his oxygen. So he's actually fine there. Someone said high blood pressure and heart rate could be due to stress from chest pain. Exactly. So remember, when you're thinking, you need to think broadly when it comes to this kind of stuff. So you can't just say, oh, his blood pressure is high, he must not be taking his meds. That's making an assumption about your patient. You need to remember that pain can cause increased blood pressure, and pain can cause increased heart rate. So, so basically, we have to, over time, we have to monitor his blood pressure, and we need to have blood pressure goals. So the American Heart Association and the American Heart Association in 2018 recommended that inpatient goals for blood pressure would be less than 130 over 80. So we can just continue his home medication of valsartan, and let's see if it like controls his blood pressure. The one thing we don't want to happen is that his blood pressure skyrockets and he gets a stroke. Let's see. What else? I would ask if he has taken his statin already today. Yeah, so one thing about all the medications is ask when they first come in, the nurses usually do an intake and they ask when's the last time they took their medication so that we can get them back on their schedule. A lot of times we're just gonna restart their home medications. And then his weight could factor into increased heart rate. I don't think that's true. His weight could be a factor that can be increasing his blood pressure like chronically. We're not sure if this is an acute increase in blood pressure or this is a chronic blood pressure elevation. Someone said yes, because he is complying with his meds currently. So that's an assumption we're making. We don't want to make that assumption. So we're just going to continue his valsartan when he's inpatient and see if his blood pressure can get down to 130 over 80. However, some things I would notice first are the vital signs, which you guys greatly, acknowledged. And then the obesity, that's another big thing. I didn't give you guys a BMI, but if he's obese, his BMI is at least 30. So that's also a risk factor for developing atherosclerosis and progressing to chest pain like this. All right, let's continue to the next slide. All right, so I want you guys to think. I know you guys aren't in medical school yet, but some of you guys have a lot of medical experience. So what are some tests we can order to help us determine what Bob has right now? Essentially, I feel like a lot of you guys have been saying that he is a likely candidate for a heart attack. So I agree. I think Bob likely does have a heart attack, right? He's having a myocardial infarction right now. So how do we confirm our diagnosis? We can't just say, oh, based on everything, we're just going to treat him like a heart attack. We need more evidence. EKG, great. Electrocardiogram. That's something we definitely need to do, and we need to do continuing EKGs. So it's called serial EKGs. That's one thing we can do. What else? Okay, a lot of you guys are saying EKG. Troponin, great, great. Troponin I specifically is the most specific marker for myocardial infarction. So that's one thing we can measure as well. And we're going to order serial troponins. We want to see that his troponins decrease over time after we treat him, obviously. Some blood tests for trop and BNP. So first of all, BNP is a pretty non-specific lab test. BNP kind of tells you there's fluid overload in a person. I know BNP is a lab we always order with heart failure patients, but Bob could have an acute decompensated heart failure right now due to the myocardial infarction, but I don't think BNP is one of the best labs to confirm a myocardial infarction at all. Okay, everyone's saying troponin and EKG. Great, good, that's very basic. Someone asked, is it a poor assumption to make that if we believe he doesn't take one of his meds, that he doesn't take any of his meds? Like if his A1C was high and we believe he doesn't take the diabetes meds. I think it would be a poor assumption because drugs have side effects, right? And let's say one drug makes you pee a lot. You don't like peeing because you have to stand at a desk and you're a receptionist all day. You're not going to take that drug because it makes you pee, but you need it because it helps with your blood pressure, right? So those are like your diuretic drugs. So I think it'd be a poor assumption to say that. A lot of patients don't like injecting insulin. And so just because like their insulin, their blood glucose and their H1 and the HbA1c is a little bit high, it doesn't mean that they're not taking their other medications. It just means they don't like injecting their insulin. And again, we need to make as few assumptions as possible. We need to treat them like another human being. We just can't make assumptions and play God. We need to make sure that we ask for a full history and we trust what the patient says. And we correlate that with our objective findings so that we can make a good assessment and plan. Someone said chest x-ray. Good, chest x-ray. So angiography and coronary angiography, that's a bit invasive. We don't want to do that just yet. But we're headed in that direction. So chest x-ray, the reason why I would get a chest x-ray, so I'll go to the next slide here, is because we want to rule MSK, which stands for musculoskeletal causes of chest pain. Like I said earlier, that could be trauma. Like if he got hit in the chest, he was playing, I don't know, football, and like a football hit him in the chest, or if he had a wound there, or if he has an infection there, or if he has costochondritis, which is inflammation in the cartilage around the bone and the ribs there, so that can cause chest pain. So yeah, cardiac troponins, CKMB, this is creatine kinase muscle bone. So we need to check that one. So look at this graph here. This is days after the onset of an MI. So if you see here, both troponin and CKMB both elevate after a myocardial infarction. Troponin I is the most specific. However, because it takes so long to taper off, CKMB is another good one to measure, because what can happen is after one myocardial infarction, it basically kind of comes back to normal after about 2 or 2.5 days. If he re-infarcts, this would be the best measure to tell us, if you guys see the graph, I see my mouse here. If he has another infarction, the CKMB would bump again. So that's why we were going to measure his CK and make sure he doesn't have another infarction. However, troponin is the best one. And just to note here, troponin is going to max out at around like 24 hours. And then CKMB will max out around 16 to 24 hours. So just right before troponin. Cool. EKG wise, okay, let's go into EKG. Let's talk about that. So a little bit about EKG. So essentially here we have our little diagram of the heart, and we have the SA or sinoatrial node, and we have the atrioventricular node. Notice these are both in the right atrium of the heart. This is the left atrium, left ventricle, right ventricle. So the way blood flows is blood flows from the left atrium through the left ventricle, out the aorta, and then to the systemic circulation, back through the vena cava, to the right atrium, right ventricle, and then out through the pulmonary trunks here to the lungs. Okay, so, but we're not really focused on that. Let's talk about the electric conductivity through the heart. So in the SA nodes where it starts, you have pacemaker cells. They're going to send signals to through the Bachman bundle, and they're going to send signals to the AV node. After the AV node, you'll get the bundle of His, and then you have these Purkinje fibers that will send electrical signals to the rest of the heart. So this is the way we measure this. We're going to put a bunch of little stickers with wires across the patient's chest, and it's going to measure something called an EKG. This is a normal EKG diagram. So real quickly, you have a P wave which is atrial depolarization, and then you have a PR interval, which is going to signify the like the pause of the AV node, and you have a QRS, which is ventricular depolarization, and then you have your T wave here, which is ventricular repolarization. So some of you guys may have taken some classes on biology or like neuro, stuff like that. And you guys learned about action potentials, right? So when action potential depolarizes, the cell can send a signal really fast down. And then, in the neurons, at least you have the saltatory conduction. So the reason I'm talking about that is because when you depolarize a cell, it's going to send the signal to the next cell. And so this is the atria are going to depolarize with P. And then the QRS is when the ventricles depolarize. And then when they repolarize, they're just coming back to their neutral state again. That's when the ventricles repolarize. And also just a little quick note that the atria will repolarize at some point during QRS. And that's why it's kind of mixed in and it gives you this weird QRS shape here. All right, let's move on now to Bob's EKG. So I put a little picture of our schematic here. Can you guys tell me what looks normal or abnormal in this EKG that we got for Bob? Just real quickly, this is lead 1, lead 2, lead 3, AVF, AVL, AVR, and then V1, 2, 3, 4, 5, 6 are just kind of the ones going across your chest like this. I'll give you guys a few minutes here. The R wave. Little activity. T wave abnormal. Okay. Yeah, I do see some T wave abnormalities. I know this is a little bit advanced, so I'm not trying to, make you guys. I'm not trying to teach you EKGs like completely here. I'm just trying to give you a quick overview and see if we can analyze this together. Okay. So the big things I noticed initially are these guys, these big ballooning segments here. Okay. And notice someone said ST segment changes in 2, 3, and AVP. AVF. Okay, so AVF. And so if you look here, it's kind of hard to see the P wave, but this is the QRS complex right here. And then you have this ST wave. So the QRS, and then right there from here to here is your ST segment. It's elevated. You have an elevation in lead 2, lead 3, and lead AVF. And another thing to notice here is that you have these reciprocal leads. So since this ST waves are going to go up here, they're going to go down on AVL. They're going to go down on V2. They're going down on AVR. And they're just called reciprocal leads for these other leads. This is, if you want to go look it up, I would look up the 12 lead EKG and how to read that on YouTube. There's a lot of good videos on that. So it's a lot about the electrical axis of the heart. Anyway, so what we're noticing is ST segment elevations in leads 2, 3, and AVF. And so have you guys ever heard of a STEMI or ST elevation myocardial infarction? So this is what Bob has. He has ST elevated myocardial infarction in leads 2, 3, and AVF. And these 3 leads correlate with something called an inferior wall myocardial infarction. So that's what Bob is having right now. Okay. All right, good try, guys. That was really good. Okay, so his labs and imaging. So we took a chest x-ray. It was negative for trauma. And he has elevated troponin I, elevated CKMB. So I think we beat this to death already, but what is Bob having and what should we do next for him? And then what are some ways we can break the news to Bob? Okay, well, everyone's probably going to say MI, so I'll save you guys that one. He's having myocardial infarction. So what should we do next? This is now like clinical management, which is usually something you learn more in like third year and fourth year of medical school. But if you guys get it, I'd be really, really impressed. Good. Someone says he will probably need to go to cath lab. Great. STEMI. Perfect. Angiogram. Good. And how should we break the news? Someone says explain that it's a serious situation, but he will get good care. Okay, that's good. He should go to cath lab. Everyone's saying cath lab. Good. Anything else? Okay, well, I'll just get started. So STEMI, correct. He has a ST segment elevation myocardial infarction. Next thing we need to do, so first of all, we need to admit him to the hospital. So that's the first thing. And he needs an emergent heart catheterization with stent placement. So when you guys say cath lab or angiogram, what you really mean is that you are having the interventional cardiologist go in. They're going to reperfuse the stenosed artery or blocked artery to the dead area and try to get blood flow back to that dead area. We want to prevent any further damage. And so to do that, we're going to put a stent in. A stent is kind of like a cylindrical shaped object. I don't have a cylinder, but it's kind of like this. You kind of put it inside the blood vessel. It kind of keeps the vessel from closing in on itself because it's usually, there's metal type that's a drug-eluting stent. I think more commonly I see the drug-eluting stent. And so that's what you're going to do. That's or also known as percutaneous coronary intervention. We're going to continue to grab EKGs and troponins to see if it goes down. We're going to give him some morphine and nitroglycerin for pain. Nitroglycerin because he has cardiac pain, morphine just for pain in general. And one thing to remember is that, so an MI is because of a plaque rupture, right? So when this thing ruptures, it's going to embolize. It can move down further and then block another segment of this artery. So we need to anticoagulate him. So we need to give him something like heparin. And then aspirin for chest pain. I think someone said it earlier, like a while back, but now we can give him aspirin. Depending on your hospital, some places will want 325 milligrams, some want 81 milligrams, but essentially you want to give him aspirin to help him with the chest pain. We're going to start him on a statin if he's not already on one. We're going to continue an ACE or an ARB. ACE stands for angiotensin converting enzyme inhibitor. And then we're also going to do an antiplatelet therapy with a drug called clopidogrel. So this mnemonic is MONA-C, MONA-BASHC. And that's all the medications I was just talking about right now. So some people were giving some help with how we should break the news to Bob. So someone said, tell him what's happening in simple terms, tell him the next steps, what are the risks, don't forget to reassure him. Perfect. So I would tell Bob, so first of all, you want to ask him how much he wants to know, and you need to tell him everything that he wants to know. Likely he's going to want to know what's going on. So you're going to tell him, exactly what's happening to him, that he's having a myocardial infarction, also known as a heart attack. We're going to give him his treatment options, one of them being invasive, which is the catheterization. And then we're going to start on some medications to help him with the chest pain and help this from progressing any worse. How much nitrate can be given if pain is still persistent? I'm actually not sure. That's a good question. I'll have to look it up and get back to you. If pain is still persistent. So I think, yeah, no, I'm not going to answer that question because I'm just going to say I don't know. And then obviously reassure him, tell him that he's getting really good care at the hospital. We're going to treat him very well. And he has a good healthcare team behind him. And we're obviously going to update his family on what's going on. We also obviously need to explain the risks and benefits and alternatives to this treatment for him before he can undergo this procedure. That goes with any kind of procedure a patient does. They must sign this, and we must obtain something called informed consent. All right. All right, so we need to form a broad differential diagnosis. Does anyone know why we need to have a broad differential diagnosis? While you guys think about that and give me some answers, I'll read to you guys, a very broad differential diagnosis for chest pain. ACS stands for acute coronary syndrome, which is what Bob has. Aortic dissection, pulmonary embolism, which is when you have the blockage of the vessels that lead to the lung, costochondritis, pericarditis. So around your heart, you have this area called the pericardium, and if that gets inflamed, it can cause chest pain. And usually these people, the chest pain will relieve when you lean forward a little bit. And then coronary artery dissection, myocarditis, which is just inflammation of the myocardium, which is the muscle layer, stable angina, or valvular heart disease, such as a problem with the mitral valve, aortic valve, etc. Someone asked me, how do you know how much he wants to know? Do you ask outright? Yes, you need to be upfront with your patient and ask them, okay, so we have the results from the lab, how much do you want to know? Often those kind of questions are reserved for cancer patients, but I do often ask that, how much do they want to know before proceeding? But generally, I do tell my patient everything that's going on with them so that they know, so they have a better understanding of what's going on. So can anyone give me answers for what is the importance of a broad differential diagnosis? Okay, I'll just start talking. So you don't want to anchor. If you guys have heard of an anchoring bias, basically what happens is, let's say the ED provider, emergency department provider, they say, okay, Bob has disease A. Well, you shouldn't anchor on disease A because they haven't had the time to sit down with the patient and spend a lot of time, and they haven't had enough time to get all the diagnostics together and then sit there and think about what's going on with the patient. So you don't want to just anchor on one thing and lead with that, because sometimes it's something else. The best way I like to approach this is I want to have a broad differential, and over time, as we get more data and more objective data, we can narrow down what's going on with the patient. And by the time they're discharged from the hospital, we have a final diagnosis of what's going on. Great. So you guys are saying it allows for multiple options for treatment. If you focus too much on one condition, it is easy to misdiagnose and mistreat. Very good. So you don't rule out any other possibilities. Perfect. Exactly what I'm saying. So just remember broad differential diagnosis when it comes to treating your patients. Okay. So this is kind of a little like a plan for Bob that we were talking about earlier. So that's something I would definitely think about when it comes to someone who presents with chest pain that's likely a myocardial infarction. Oh, and one thing to note is that if someone gets a drug-eluting stent, you want to keep them on dual antiplatelet therapy for 1 year. So the dual part is aspirin and clopidogrel for at least 1 year after drug-eluting stent. Okay. So what is Bob's prognosis? So likely he's going to be fine after the cath lab and a placement of the stents, but now he definitely has to follow up with the cardiologist. And since we caught his STEMI early on, he'll probably be fine. I can't say for sure, but he'll hopefully be fine. But after an MI, you have risk of so after catheterization, you put the stent in, there's actually a risk for restenosis. It can just close in on itself again. So that's one risk that can happen, which we need to explain to Bob before he goes to procedure. And after any kind of myocardial infarction, you can also have fatal arrhythmias, which are usually like ventricular arrhythmias, like VFib. And make sure he takes his medications and just educate Bob on how to take care of himself in case he's not already doing so. I already talked about the anticoagulation thing. And so the last question is, can Bob start exercising after he recovers? Should he? And when I say recover, I mean like after he gets discharged from the hospital. Should he start working out right away, or should he wait? And then later on, should he have a long-term exercise? And why? Someone said yes. Someone said no. Okay. So right after he gets out, okay, maybe start, since someone said maybe start light exercise like walking and work up to something more rigorous. Okay, like a stepwise approach. Someone said yes to avoid plaque buildup. Okay, so to answer the first question, can Bob start exercising right after he gets out of the hospital? Probably not. He shouldn't. He should make sure he's stable, make sure he follows with the doctor and gets the okay to start working out again. However, long term, he should definitely work out so that he can first, because he's obese, right? Losing weight is going to help with his high blood pressure. Losing weight is going to help overall. So, and it's also really good for his cardiovascular health. So, some kind of aerobic training, like, so he's 55, so he can do like an incline walk, he can jog, he can walk his dog around the park. He can go swimming. There's a lot of activities he can get involved in. I think this is something the role of primary care physician can play here in educating the patient on what he can do to best improve his long-term outcomes. Cool. Good job, guys. All right, so I hope you guys found this helpful. Chest pain is really, really common. I hope you guys learned a lot today. Some take-home points today with angina versus myocardial infarction. So angina is reversible. Myocardial infarction is irreversible damage. We talked about the anatomy of the heart, how the left anterior descending is the most commonly occluded vessel, but we also talked about how the inferior wall MI can be associated with the 2, 3, and AVF leads. How do we diagnose the MI? Remember the CKMB, the troponins, EKG, and then how we're going to treat him. And then also remember, at the end of the day, patient compassion is key. We need to remember that humanism in medicine is extremely important. Remember, patient's day in the hospital is the worst day in their life. It's just another day of work for you, but it's their worst day. You need to treat it like such, and you need to be compassionate with them and really become empathetic and understand. Remember, like, why you went to medicine in the first place. So this is my quote for you guys. If you guys create a sense of urgency in your education, you'll prevent procrastination. I know tons of medical students, pre-medical students, doctors procrastinate a lot, but for me, I think what really helped me the most is I always create a list of things to do, and I create like, I want to be ahead of the deadline. So if my exam's on Wednesday, I'm ready by Monday. If my thing's due on Wednesday, I finished it by Monday as well. So I want to make sure I'm always ahead of the game so that I don't procrastinate. This is creating a sense of urgency. So I hope that sticks with you. Hopefully it gives, helps you guys a bit. And here's my contact information. That's my email. My Instagram is mdeadlift. So there's a lot of lifting content, some medical content. And then White Coat Tutors is the company I own. If you guys want to give that a follow, we post medical content and little tips and sometimes memes. So I hope you guys enjoy that too. Thank you guys for tuning in today. And I really, really thank you for selecting me to do the internal medicine shadowing session today.
Thank you so much, Dr. Phan. It was an honor to have you. We loved how interactive you made the presentation. It definitely made it feel like we were actually in the room with you, shadowing you.
Awesome. I'm glad. If you guys have any questions, just feel free to DM me or send me like an email.
No, sorry.
Oh, is this still live? Yeah, it's still live. So yeah, if you guys have any questions, feel free to do that or quickly send it through the Google form and I can answer them right now if you want.
Everyone, make sure you check out his socials. His Instagram is mdeadlift and White Coat Tutors. The link for today's Google form has now been posted in the chat box. Please fill it out within the next 30 minutes for us to receive your attendance. And it'll be in the description of this video shortly. Again, thank you so much, Dr. Phan.